Today we'll be discussing about pediatric restorative materials, the most commonly used materials in pediatric dentistry for restoration. So, let us know what are the ideal characteristics or the virtues of a restorative material which needs to be placed in oral cavity of a child. First of all, the ideal characteristic should be that it should be biocompatible to the oral tissues. It should not produce any harm on the oral tissues and it should match with the oral tissues properly. It should be aesthetic, that is, it should provide a proper visuality and it should match the shape, the size, the form and contour of the tooth. Secondly, it should be able to bear the occlusal forces, the tangential forces which are subjected in the oral cavity of a child. Whenever a child bites, the material should not be such that it should crack easily. Then the material should be aesthetic. It should be biocompatible. It should be resistant to the tangential and the occlusal forces. Then also it should prevent the ingress of the bacteria into the tooth surface or wherever, for example, if the tooth surface is cut and the material is placed in place of the tooth surface, the material should be providing a barrier against the bacteria or the saliva or any such external things. Then it should also provide a long-term adhesion to the tooth surface, that it should not be easily removed from the tooth surface by some external forces. So it should have a proper resistance to the removal from these external forces. So summing up, it should be biocompatible, it should have proper aesthetics, it should have proper strength to bear the occlusal forces, it should not prevent the population of any oral fruits or oral bacteria from the oral cavity or from outside, and finally it should be very retentive to the tooth surface. It's better that it is bonded to the tooth surface easily. So let us discuss the most used material in pediatric dentistry, which is glass ionomer cement. The glass ionomer cement was discovered and put forward by Dr. Wilson Kent in the year 1972. So glass ionomer is nothing but it is a polyalkenoate cement. It is a mixture of polyacrylic acid, that is acid, and a base which is glass. So when these two react together, they form the glass ionomer cement. Now, what are the special properties of the glass ionomer cement which make it a proper material of choice in pediatric patients? So, first property is the anti-cariogenic property of the glass ionomer cement. This is also a fluoride releasing cement. For example, in the composition of the glass ionomer cement, there are certain elements like aluminum fluoride, calcium fluoride, aluminum silicate, which release the fluoride ions into the oral cavity. Thus, it prevents any demineralization and promotes the remineralization of the tooth surface. As we've already discussed the role of fluoride in the anti-kerogenicity in the preventive dentistry chapter, so we'll not be going into further details. So it has excellent fluoride releasing property. It has excellent biocompatibility, that it is biocomparable or it can be easily accepted by the oral tissues. It does not cause any harm on the oral tissues. Then nextly, it is aesthetic material. The tooth color or the refractive index of the glass ionomer cement matches the normal tooth color. Then it can also wear the external forces or the masticatory forces in the oral cavity. It is bonded to the tooth surface by the means of a chemical and the mechanical bond. The mechanical bond is created by etching by the polyacrylic acid, and the tags of the glass ionomer cement goes into further these porosities. So this is a mechanical bonding, and in the chemical bonding there is a procedure which is involved and various chemicals are formed or compounds are formed which covalently bound to the tooth surface. Then it also has excellent translucency, that is the translucency of enamel can be matched by the glass ionomer cement. Next, coming to the classification. There are various classifications have been put forward for the glass ionomer cement. Type 1 is called luting cement, type 2 is called filling cement, and type 3 is called for liners and bases. There is another classification in which there are 9 types of classes of the glass ionomer cement. Again, in which type 1 is luting, type 2 is filling, type 3 is liners and bases, type 4 is for the core and build-ups, type 5 is for the orthodontic brackets, type 6 is for the light cured glass ionomer cement, type 7 is a pit and fissure sealant, type 8 is for geriatric, and type 9 is for the pediatric use. Type 8 is also known as the light cured glass ionomer cement. Then coming up to the classification on the composition of the glass ionomer cement. The glass ionomer cement is usually available in the form of a powder and a liquid. There are two bottles, one is dispensing the powder and another is dispensing the liquid. Now let us see what does the powder of the glass ionomer contains. It basically contains the glass particles. So the composition is, first is the silica, which is the filler of the glass ionomer cement. It helps in strengthening the glass ionomer cement and forming the filler or giving bulk to the glass ionomer cement. Next is the alumina. It is present in 16.5% by weight, and alumina, it reacts with the acids which are present in the glass ionomer cement and forms further reaction of setting. Then comes calcium fluoride, aluminum fluoride, which helps in workability of the glass ionomer cement and improves the working characteristics. The aluminum fluoride also decreases the temperature of fusion of glass ionomer cement. Next comes the aluminum phosphate. The aluminum phosphate controls the setting time. It can increase or decrease the setting time of the glass ionomer cement. Usually the mixing time of glass ionomer cement is 35 to 40 seconds and the setting time is about 1 minute or 60 seconds. Next comes the liquid. The liquid of the glass ionomer cement composed of the polyacrylic acid, the malic acid, the artenic acid, the lactic acid and the tartaric acid. So the polyacrylic acid is basic acid which reacts with the glass particles or the alumina to form other polyacrylates, which helps in hardening the glass ionomer cement. Next comes the itaconic acid or the malic acid, which helps in the workability of the glass ionomer cement. The itaconic acid reduces the viscosity which is created by the glass particles and it helps in the flowability of the glass ionomer cement and gives it a resilience. Then comes the tartaric acid. The tartaric acid, when added, reduces the working time of the glass ionomer cement. That is, it makes the cement more time for the setting. So it gives a more working time for the glass ionomer cement. Now what is the setting reaction? The setting reaction is composed of the dissolution of the particles of the glass in the liquid, then the gelation, and final is the hardening. In the dissolution of the glass particles react with the water content and all the aluminium ions, the calcium ions, the fluoride ions are released by the means of reaction of the glass particles with water, or the silica and aluminum fluoride particles, the calcium fluoride particles, the aluminum phosphate particles with water. Finally, these free cations are released and they attract the polyacrylic acid and forms aluminum polyacrylate, calcium polyacrylate, which is responsible for hardening and gelation. The final mass is formed of the matrix of the calcium aluminum polyacrylate and silica polyacrylate, and the outer ring of the silica gel is formed. So this is the final composition of the glass ionomer cement after setting. We should keep in mind that water should not keep in contact or come in contact with the glass ionomer cement while setting. So it should be done in proper isolation, and proper suction should be there to prevent any water or saliva from coming in contact with the glass ionomer cement while the setting, because this will prevent the setting of the calcium polyacrylate, and this will leach away all the ions or the cations which are formed and which will affect the final hardening of the cement. So only after a minute, only after the final setting of 30 minutes have taken place, then only the patient should ask to eat or drink anything. So the setting time is for the type 1 is 4 to 5 minutes and type 2 is 7 minutes. Here we have already seen the mechanism of action or the mechanism of setting of the glass ionomer cement, where the polyacid dissociates into the cations like aluminium, fluoride and carboxylate, and they form a cross-linked polyacid gel. The final hardening takes by the polyacid liquid. When it forms or attracts aluminum ion, it forms a cross-linked polyacid. And we have the core of the glass and the silica gel surrounds the particles or the setted glass ionomer cement. Now let us see how can we manipulate the glass ionomer cement. First of all, we do not use a glass slab in mixing the glass ionomer cement. In fact, we use a paper pad for mixing and an agate or the plastic spatula for mixing the glass ionomer cement, because if we mix it by a metal spatula or on a glass slab, the ions will leach away and this will also lead to the discoloration of the cement. So first we dispense the powder from the jar of the glass ionomer cement. A scoop of powder is dispensed from the jar. Often the manufacturer instructions are written on the bottle that how much or how many grams or how many scoops of glass ionomer cement powder needed to be taken for a drop or 2 drops of the liquid. This will depend on whether what type of glass ionomer cement is there, whether it is for use for luting, whether it is used for restoration, or it is used for any other purpose, or a Patent Fisher sealant. So in the type 1, that is for luting, 1.25 grams for 1 ml of liquid is used, and the other type 2, 3 grams, and type 3, 1.5 grams is used approximately. The mixing time of glass ionomer cement is usually 30 to 45 of the seconds. The glass ionomer cement is first dispensed on this thing, which is a paper pad, and is divided into 3 small increments. First, we'll incorporate the first increment into the liquid after dispensing the liquid onto the paper pad from the bottle. And first we'll mix the first increment, then we slightly tap all the powder in the liquid so that the powder dissolves in the liquid, and mix it by a folding motion. Then the second increment, the third increment is added by the folding motion of the spatula on the paper pad. And final, the mix, we'll see that it is glossy in nature. So what are the advantages of the glass ionomer cement? One of the main advantage is its aesthetic property, that it matches exactly the translucency and the consistency of the tooth structure. Second, it is a fluoride reducing cement which has anti-cariogenic property which prevent the caries and promotes the remineralization of the tooth surface, further preventing the demineralization. It also bonds to the tooth surface by the means of the chemical and a mechanical bond. And the disadvantages are that it cannot handle very high occlusal forces. That is why it is not used in class 1 and class 2 type of cavities generally. Then it can also not hold any tangential forces. Sometimes it can lead to micro leakage, and it is moisture sensitive. There are certain modifications of the glass ionomer cement like anhydrous glass ionomer cement, in which only powder form is available. So there's no liquid form in anhydrous glass ionomer cement. Then the second is the compomer, which is a combination of the composite and the glass ionomer cement. The third is the resin modified glass ionomer cement, which is the composite, or which is the combination of the glass ionomer cement and the resins, which has superior properties and both the properties of the resin cement and the glass ionomer cement. Next comes the amalgam, or the combination of amalgam and the glass ionomer cement, which is usually can be used in posterior cavity and has further fracture resistant and is more resistant to fracture and has more strength. There is the ceramic reinforced glass ionomer cement and the nano ionomer. The nano ionomer has a very small particles and has higher translucency and aesthetic property than any other glass ionomer cement. So these were the properties, the advantages, the disadvantages and further characteristics of the glass ionomer cement. Next we come to amalgam. Amalgam, or the silver amalgam, is generally used in permanent teeth, but it can also be sometimes used in the primary teeth. Amalgam is nothing but it's a combination of various metals with mercury, and dental amalgam is a combination of copper, tin, silver with zinc with mercury. The classification of the dental amalgam can be classified into the either unicomposition or bicomposition or semi-composition according to the number of the particles. Then comes according to the shape of the particles, they can be either lat cut, that is they are pointed type of particles, and spherical, which is the spherical type of particles, and admixed have both the lat cut and the spherical particles and have both the properties of both the particles. In the unicomposition, it contains only silver with copper, or in the bicomposition, zinc is also there, and the tricomposition, other metals are also there. Then according to the size of the particle, it is micro cut, very small size, and fine cut, which is greater than 35 microns, and coarse cut, which is greater than 35 microns in size. Then according to the composition is zinc free, which do not have any zinc containing alloy, having the zinc content, and pre-amalgamated alloy. That means the alloy particles are pre-coated with amalgam. And according to the dispensing system, they can be either contained in a capsule or they can be amalgamated in the amalgamator. Then according to the copper content is the high copper, where they contain more than 6% of copper, and low copper, where they contain less than 6% of copper. Then the unicomposition or the single composition and the copper enriched alloy. They may be either the lat cut or spherical. Now coming over to the composition of the amalgam. The amalgam can be either high copper or low copper, in which the high copper, the copper content is from 13 to 30%, and low copper is from 2 to 6%. The other components of the amalgam are zinc, which is usually 0 to 2% in both, then mercury, which is 0 to 3% in both, and tin, which is 26 to 28% in the low copper, whereas in high copper it is 27 to 30%. Then silver is 68 to 70% in the high copper alloy, and in the low copper alloy it is 40 to 60%. Now coming over the individual properties of the low copper and the high copper alloy. The low copper is traditionally used copper alloy, and it has inferior properties than the high copper alloy. It can either be lathe cut or spherical, and can also be micro cut. It has a gamma phase which aids in the weakening of the alloy particles or the amalgam. So it's generally not used in posterior parts of the oral cavity. Then high copper alloy excludes the gamma phase, which is an acetting reaction of the amalgam alloy. So this gamma phase is eliminated, which leads to increased strength of the high copper alloy. Generally, two forms are there, admixed and the unicomposition of the high copper alloy. Now there are other properties of amalgam like packability. That is, it can be easily packed into the cavity which is formed after the cavity cutting of the tooth, whether it is a class 1 or a class 2 cavity. So it can be condensed by the means of the amalgamator in the cavity and the condenser. Next is the trituration. What is the trituration? The trituration is the mixing of the amalgam with mercury. That is, and so that all the particles of the amalgam are wetted by the mercury, and further the amalgam is formed. So there are various methods of mixing by the means of a pestle or a mortar, then an amalgamator, which is also known as dentomat. Now, what is the procedure of trituration of amalgam? So first we dispense the amalgam powder, then we use the dispensed mercury. Then after that, taking in a pestle and mortar, we go by rolling motion, and final mass is obtained, is taken in a gauze piece, and it is squeezed so that excess of mercury is escaped from the amalgam, and final mass, which is condensable, is obtained and is carried to the oral cavity by the means of the amalgam carrying instrument or the amalgam syringe, and it is inserted into the cavity, and finally it is condensed by the means of an amalgam condenser, so that all the walls of the oral cavity are in contact with the amalgam. Now, after the condensing, we do carving of the amalgam to simulate the entire occlusal anatomy of the tooth surface and to ensure that all the tooth surface or even each and every line angle and point angle is in contact with the amalgam restorative material. Final, after carving, the burnishing is performed. Burnishing is performed by a ball burnisher to excavate or to remove any further irregularities from the tooth surface. It is always done from the center to the periphery. Then the final polishing is done to prevent any corrosion. The advantages of the amalgam are that it maintains the anatomic form, it is cheaper, it has a longer life duration, and prevents any marginal leakage. The disadvantage that it is not tooth colored like glass ionomer cement, so it will give a greyish appearance. It can only be given in the posterior parts of the cavity. It does not bond to the tooth surface, it is not fluoride releasing. It can also subject to galvanic action if it is kept, or if for example in the upper arch gold restoration is done and the lower arch amalgam restoration is done, it will lead to galvanic action. That is, they can act as electrodes and lead to electric shock into the oral cavity. Then there is also risk of mercury toxicity by the means of amalgam, or mercury can escape from the amalgam and lead to mercury toxicity. Now, coming to another material of choice for the pediatric patient, which is composite. Composite is nothing but it's a physical mixture of various materials. So it is ideal for anterior teeth and it has an excellent color property and aesthetic property. The word composite was first discovered by Dr. R.L. Bowen. So composite basically composed of matrix and various filler particles which are distributed in the matrix. The composition contains of the resin matrix, which is bis-glycidyl methacrylate, and the filler particles like quartz, silica, etc. Then it contains the coupling agent which helps in covalent bonding of the filler particles to the matrix. Generally, they can be zirconates or titanates, but recently there are certain materials like silanes, trimethoxysilane, which is added as a coupling agent. Then there is an initiator or the activator system like benzoyl peroxide. For example, there are various types of composites which are light cured, chemically activated. In the chemically activated composite, benzoyl peroxide is added. Another aromatic ene, which is N,N-dimethylparatoluene, is added as a activator. In certain light curable composites, the photosensitive elements are added like camphoroquinone or titanium dioxide, the dimethylamino-methacrylate. Inhibitor is added, which is a butylated hydroxytoluidine, which is an inhibitor to prevent further polymerization reaction to take place. Then the optical fillers like titanium dioxide and aluminum oxide are also taken. So the final set mass of composite consists of the resin matrix and the inorganic filler in between. The resin matrix will surround the inorganic filler particles. The classification of composites can be either the conventional composite, which contains more of filler particles like 75 to 80%. They have more strength but have inferior aesthetic properties. Then comes the microfill. The microfill have a more smoother texture. They have the particle size between 0.01 to 0.04 micron, and the inorganic content of the fillers is about 35 to 60%. They are clinically more water resistant. Then comes the hybrid composite. The hybrid composite is the mixture of the normal particle size composite like the conventional composite and the microfill composite, and have the properties of both. They have approximately 75 to 80% of the filler particles. Then comes the flowable composite. The flowable composites are generally used for luting purpose or in the pit and fissure sealant or in the use of the splinting or certain space maintenance. The flowable composites have inferior properties and inferior fracture resistant than other type of composites. The packable composites are those which can be easily packed into the cavities formed by the tooth preparation. Then is a nanofiller composite, which has highest translucency and smoothest of the all. It has the filler content of about 35 to 40% and 0.01 size of the particles. It has good physical properties. The composite have good radio opacity, which is attributed to the titanium dioxide which is present in the material. It is also helps in detecting any caries which is present below the knee cut cavity. It has a good modulus of elasticity or the resilience. It is also a water absorption properties, so water contamination during the preparation of composites should be avoided. It has a good fracture resistant, and the surface texture of composite is the best amongst all. Generally, microfill composites or the nanofill composites have the best surface texture and provide the best aesthetics. So, how can we place the composite resin? First of all, the tooth is oral prophylaxed and all the dirt and the grim from the tooth is removed by scaling and polishing. Then after that, we just I properly isolate all the tooth surface or the oral cavity. Then we etch or prepare the cavity. Then after that we etch by the means of 5% polyacrylic acid, and after etching the hypophosphoric acid, and after etching the surface is properly washed by the means of a jet of water for 10 seconds actually. Then it is dried. Then the bonding agent is applied for 20 to 30 seconds. After application of the bonding agent, the composite is placed layer by layer and it is cured according to the manufacturer instructions, and finally it is contoured and polished. The indication of composite are generally class 1, class 2, class 3, 4 and 5 type of restoration. It can also be used as a pit and fissure sealant, or it can also be used in a splinting of the tooth. It can also be used as partial or full veneers. It can be used in a fractured tooth, the class 1, class 2 type of fractures. It can also be used in post and core buildup in the case of fiber post. It can be used as a cement for restoration, as a temporary dressing material, and the periodontal splinting. The main contraindications of composite, it should not be placed in a very cavity in which there is a high occlusal stress and in where isolation is not proper or isolation cannot be there. In such cases, composites are contraindicated. And the advantages are that it is aesthetic, it is properly bonded to the tooth surface, it has superior physical properties than the glass ionomer cement, it is bonded to the tooth surface, it is repairable, and it is used almost universally. The major disadvantages are that it can absorb water easily, so it is used generally in the case of high isolation. It is technique sensitive and it requires a good number of equipments, and it also requires a curing light. Sometimes it can lead to occlusal wear. Sometimes marginal percolation or marginal leakage of composite is also possible, leading to the oral fluids to ingress in the composite film cavity. So these were the properties of the composite which were discussed, and it is one of the most superior materials for restoring the primary teeth. Thank you.